Thank you indeed. That was a really great talk to really start the conference off on a really positive note. And that will continue with our next speaker, who's my co-chair, Nittaya, who's going to present on U equals U, the science of U equals U. Nittaya is from the Institute of HIV Research and Innovation in Thailand. Again, is a very well known physician, has done a great deal of work on HIV testing, prevention and treatment in men who have sex with men, and indeed in transgender women. And she works actively with the community and the government to establish technical assistance platforms to support accreditation and legalization for lay providers to ensure that everyone gets the best treatment that they can. Nittaya.
Thank you very much for giving me an opportunity to talk about U equals U science in the Asian Stigma Discrimination Forum 2020. Today I'm going to talk about U equals U science in some details, and then discuss about the concerns around healthcare providers, which will lead us to the discussion around the U equals U communications, and to discuss also how we can integrate U equals U into our practices, regardless of our roles in these mutual efforts to end AIDS in the next 10 years. I'd like to start with this U equals U science timeline, just to show you that U equals U science actually started almost 2 decades ago. And that's why it is so crucial for us to see why we still couldn't translate this science into implementation. And in the year 2000, the RACHI study published for the first time showing the increasing transmission risk with increasing viral load, and also demonstrated that there was no transmission if viral load is less than 1,500 copies per mil. And then in 2008, the Swiss statement issued saying that an HIV positive individual not suffering from any other STD and adhering to ART with a completely suppressed viremia does not transmit HIV sexually. And there was controversy during that time. And then in 2011, the HPTN-052 demonstrated 96% reduction in linked transmission in mainly heterosexual couples who were randomized to receive early ART. And then in 2014 at CROI, the Partner One study presented their preliminary findings showing zero linked transmission in heterosexual and gay couples with more than 44,000 condomless sex acts when the HIV positive partners had viral load less than 200 copies per mil. And there was a caveat here that there were too small number of gay couples, which lead to the need to conduct the Partner Two study. And then in 2016, the Partner One study published their final data, again showing zero link transmission now with more than 58,000 condomless sex. And the HPTN-052 study also confirmed the long-term preventive effect of ART after 5.5 years. With transmissions in HPTN-052 only occurred when viral load was not undetectable. And the U equals U campaign was also launched that year, trying to bridge this science into actual implementation. And then in 2018, the Opposites Attract study, which was conducted in Australia, Brazil, and Thailand, also confirmed the zero-linked transmission in gay couples with almost 17,000 condomless sex acts. And last year, 2019, the Partner 2 study was then published, confirming zero-linked transmission, this time only among gay couples with 76,000 condomless sex acts. And this table summarized the key information from these three studies, Partner 1, Partner 2, and Opposites Attract, which all showed zero-link transmission among either heterosexual couples or gay couples. But in the statistical world, you will get this upper 90% confidence interval number, which basically just to inform you how precise the zero transmission is. And to understand this 95% CI number, we can see here that the more number of couples and the more number of couple years of follow-up you have, then you will get a lower 95% CI or a narrower confidence interval, which means that the precision is getting better, or you get less fuzzy in the precision. So, for example, to compare the partner 2 study and the opposites attract study, which both show zero linked transmission among gay couples, you will see that we have a higher 95% CI number here, just because we have much lower number of couples and couple years of follow-up among the opposites attract study. And then how to interpret this 95% CI. The 95% CI actually just tell you that there is still 5% chance that you may see, let's say, one transmission among the couples. If you conducted the partner 2 studies for 20 times, you will see one time, you have one time that you will see one transmission happening. And then the number itself, let's look at the 0.23 per 100 couple years of follow-up in the partner 2 study. It translates into the opportunity that you may find one transmission in one couple if you followed up this couple for 435 years. So what we can learn here is that these 3 studies showed zero linked transmission among almost 130,000 condomless sex acts when HIV positive partners had undetectable viral load, and that there were similar levels of confidence in U equals U for both gay men as well as for heterosexual couples. And U equals U stays true even when STIs were detected in a quarter or more than 1/3 of HIV positive partners. And also, very importantly, we can see here that more than 1/3 of gay couples reported condomless sex with other partners outside of this stable relationship, which point to the immediate need of PrEP for these negative partners, regardless of their positive partners' viral load status. And with all this knowledge, we still obviously see concerns among healthcare providers when communicating U equals U. Let's talk about these 2 concerns first. And we can see here that many healthcare providers feel that now that the condoms are not required to prevent HIV transmission if a person is undetectable, and even if that person has STIs, providers may be very worried that that person will stop using condom and STI and unplanned pregnancy will increase. But we have to be clear that U equals U message always supports option to prevent STIs and pregnancy if there are risks. Right? We just need to stop using telling incorrect message that even if you have undetectable viral load, you still have this very small chance of transmitting HIV. Just to get people to use condom, we just need to use other reasons to convince people to use condom. And then the next concern is around providers don't trust their clients to be able to sustain good adherence to ART, and they just want to wait until they can trust their clients. But the question is when and why don't you just use U equals U as an incentive to maintain the best adherence? And these 2 concerns, I would say, are very important because it actually points to the intrinsic stigma that you may have, the unconscious stigma within you yourself towards PLHIV, being irresponsible person, irresponsible in sex or irresponsible in taking medicine. So we will need to address that quite seriously. And then there are a few more concerns among healthcare providers. The first one is around viral blip. But what we have to know is that there is no evidence that blips can increase HIV transmission, although you will have to make sure that this is a true blip. And then the next one is around people having undetectable viral load in blood but still have detectable viral load in other body fluids, and here it's probably genital fluids. And it is true that you may be able to detect viral load in genital fluids even though you have undetectable viral load in the blood, but that level in genital fluids will not be able to transmit to any people. And then the next one is around applying U equals U for non-sexual transmission of HIV. And the knowledge that we have as of now is that U equals U provides zero risk of sexual transmission, although it does not completely eliminate risk through other transmission routes, although it does reduce the risk, but not completely eliminate risk. And then the next two concerns is around this one is around condom use and HIV prevention. Isn't condom use a safe sex? The answer is yes, condom use is a safe sex, but sex with someone who has maintained an undetectable viral load is even a safer sex. And the last one is around the frequency of doing viral load testing. Will U equals U still apply if I can only do annual viral load testing, such as what we are doing in Thailand? And the answer is that the client's adherence and their relationship with you may be the most important things to determine undetectable viral load, and not the frequency of viral load testing. But with all this knowledge, with all these explanations, I think that you will all agree that we still are facing problems with U equals U communication. It is very often that we see some moderation to the zero risk language, moderation into something like just close to zero risk, or virtually no risk, or greatly reduced risk. Why don't we want to say that there is zero risk? Is it because inadequate knowledge, or is it because disbelief, or is it just because this moral judgment or implicit stigma towards PLHIV being a responsible life? I already mentioned about this, and we all really need to explore ourselves and address that. But at least I think all of us have to be clear that U equals U is not all about condomless sex, but U equals U is about PLHIV being non-infectious and reducing stigma against PLHIV, and about reducing self-stigma among PLHIV. So I think it is now time that we need to integrate U equals U into the status neutral approach to HIV, because U equals U is such a powerful message that will get people into HIV testing, into this status neutral approach in which we actively engage the person regardless of their HIV status, and support them towards the final common goal of that person having negligible risk of either transmitting HIV because of U equals U, or of acquiring HIV because of the use of PrEP and PEP. So to conclude, we now know that HIV infection is a chronic, non-communicable health condition, and people living with HIV with undetectable viral load is not an infectious agent. The risk of sexual transmission is zero. So we now have to be more confident in saying this clearly and loudly. And although research may be needed to study undetectable viral load and other routes of HIV transmission, this should not keep us from implementing the strong science of U equals U for sexual transmission that we already know. And now it is time for everyone to overcome concerns which have delayed or have toned down full integration of U equals U into clinical services and programs for the benefit of the individual people living with HIV and for the societies. Thank you very much.